Hi everyone, my name is Allain and I am a master's student in health professional education. I will be delivering a cocktail talk today, and I brought my own cocktail because I asked Adam earlier in the day if I could have one, and he said that he could not provide me with one. So, I digress. I would like to present just a little snippet of my research, which focuses on conscientious objection of Catholic hospitals in rural Canada. And it's a little bit different than maybe what you've been hearing today. It's not qualitative, it's not quantitative, it's normative, and takes a more philosophical feeling. Conscientious objection, should clarify, is a refusal to comply with approved medical requests or services based on either personal moral beliefs or religious moral beliefs. So it's not necessarily that the service cannot be delivered or they're not available. It's that the person fundamentally objects to providing the service. In Catholic hospitals, there are services that are prevented. These include abortions, sterilizations for birth control purposes such as vasectomies or tubal ligations, cryopreservation, in vitro fertilization, emergency contraception, and artificial insemination. And most of the research around conscientious objection and the ethical ramifications of it has really only looked at individual healthcare professionals, nurses, doctors, pharmacists, and they haven't really looked at more of an organizational perspective of hospitals. And furthermore, there's even less research about the rural areas. So today, I would like to talk to you about the different barriers that women and men can face when they come to accessing reproductive services in a rural area with Catholic hospitals. Now, access can be affected by multiple issues, and what may be access for one person could be a considerable barrier for another. So as I'm talking about these, keep that in mind. And also, when accessing in a rural environment, services can be hard to come by in the best of circumstances. And these can be made even more difficult to access when you're talking about vulnerable populations, such as people of low socioeconomic status, people with disabilities, and I would even include women in here, although we might not necessarily identify ourselves as a vulnerable population. So what are some of these variables? And this isn't an exhaustive list, but they are ones I think that really severely impact access. Transportation. So when we're looking at rural areas, roads can be seasonally affected. We've had so many storms this year, we can really, I think, feel what it's like to be stuck in your house or to not be able to get out and to access something. And when you're in a rural area, the roads can really be affected by winter storms, ice, and they can often be closed. When I'm talking about transportation, I'm also talking about public transportation and whether or not this is readily accessible or it could be limited. There might only be one bus a day there and back to the next closest town that offers the services to which you would like to have access. The next is cost. And cost is especially an issue for people with potentially low job security. If I'm working at McDonald's, I don't have the leisure of taking a paid sick day to go to a town an hour away and have an abortion procedure done. I have to incur the cost of a non-working day, and then I also might have to spend money for transportation, for meals, for elder care or child care, and any other services that I might need to. I might need to buy medication. I might not have an insurance plan. The next is time. And when we're talking about reproductive services, a lot of them are contingent upon time. Emergency contraception, for instance, has to be administered for best possible effectiveness within 72 hours. And when we're looking at rural areas, the time can be an impeding factor to accessing these services, such as road safety or cost. The next is age. And youth have, sorry, I skipped confidentiality, didn't I? So confidentiality, and this is an issue often identified in rural settings because there's often overlapping roles. So my football coach might also be my mom's best friend, who might be married to my physician. It's a little bit of a story. And leaving town might require you to tell others. And now we'll get back to age. So age is an interesting idea because age. It's coming up differently on the screen. Age is an interesting factor because youth actually have an increased dependence on others. They're further limited by things like cost and time and transportation and confidentiality, and their presence is really known, or their lack of presence is really known in the community. When you're in high school, if you missed a class, usually there would be a call home. So there's increased reporting that if you miss a class, there'll be a call home, and then you'll have to explain. Explaining might mean I had to go to another community to get emergency contraception. And finally, health literacy. Health literacy is defined as the ability to access, to understand, and then to use the information that you were able to access about health. And this can be limited by education, as well as your access to that information. How comfortable would you feel going to a public library to look up on a computer where you could get an abortion? Especially in a rural area where that library is frequented by a number of the people in that community whom you know and whom you've known for your entire life. What's on the screen for you to see is also on the screen for everyone else to see. So, what this is all sort of coming to talk about is that as healthcare researchers, we know that, the hub and spoke model is a little bit too simplistic, and that we're all affected by things that are social implications on health and the external factors. So this hub and spoke model is really working within a larger scheme where each can impact our access to health, and they can build upon each other to really create barriers. But this also seems a little too simplistic, that each barrier only tends to itself. So really, if we think about it long and hard, all of these barriers contribute to a total burden of access quotient, where each compounds and contributes to each other, leading to a sum much larger than its constituent parts. This is really something I would like for you to think about the next time that you walk into a hospital or walk to a pharmacy and would like to procure any sort of service, whether or not it's regarding reproductive services or not, because sometimes it's not as easy as it seems.